celebration. Last week we were dealing with the mental health, and this week we're going to be dealing with the physical health. And we are blessed in a tremendous way to have Dr. Stephen Cavanah with us, in that he is a specialist and going to be focusing on today diabetes and talking about in the metabolism. Dr. Cavanah is an endocrinologist in Louisville, Kentucky, and is affiliated with multiple hospitals in the area, including Norton's Children's Hospital and Rob Lee Rex Veteran Affairs Medical Center. And he's received his medical degree from the University of Louisville School of Medicine. Go Cards! And has been in practice for more than 20 years. And there is a whole host of things that he is in terms as a specialist in, but I'll let him take care of the rest. We want to show him a warm welcome to Dr. Cavanah. Thank you so much for being with us tonight.
Thank you. Appreciate it. Well, let me tell you a little bit about myself. I'm from Hopkinsville, Kentucky. Hoptown. Christian County High School. So I graduated from high school in 1972. And it was kind of a circular route for me to go to medical school. When I graduated from high school, the only thing I wanted to do was play basketball. So I played basketball for a couple of years at a junior college, and then I transferred to the University of Kentucky, where I did not play because I'm terrible. Every time I touched the ball on the practice squad, they stole the ball from me. But I did raise the grade point average, just letting you know. So I ended up taking an ROTC scholarship at the University of Kentucky. So I got commissioned a lieutenant when I graduated from college at the University of Kentucky, but had already been accepted to medical school at the University of Louisville. So the Air Force paid for my college, and then they paid for medical school. And then I went into the military. I did my fellowship training in San Antonio, Texas, and had a fairly extensive military career. You might not know this, but I actually in the military served in Washington, D.C. for 9 years. And I was assigned to the White House as the physician to the president during the Clinton years. So a long time ago. And the way that I ended up there was his predecessor, George Herbert Walker Bush, had a thyroid condition, Graves' disease. So they interviewed me as a new White House physician because he and his wife had a thyroid condition. He lost the election, and I thought I wasn't going to the White House, but they said, hey, you're on a list of a half a dozen candidates, mid-career physicians in the military, and we've kept your name on the list. And then they interviewed 6 of us, and then they picked me. I think because I was the only one that could pass the security clearance, because I had never done anything bad in my life. So I'm going to talk to you about diabetes, and to put this in context, you'll notice this finger with a drop of blood on it. Before the age of finger stick blood sugars, the only way we had to monitor diabetes was to check glucose in urine. And there was an investigator in Belgium from the 1940s up to the 1980s who categorized his patients based on those who had a lot of glucose in their urine, which means their glucose in their blood was very high, and those who had very little glucose in their urine. And he was able to demonstrate in his 40 years of data that those with the best glucose control had the least long-term complications of diabetes. But it was pretty crude data because it was based on glucose in urine. With the advent of fingerstick glucoses, we were able to achieve much better control and bring those average blood sugars down. And now fingerstick glucoses have been supplanted now by continuous glucose monitors. So you can put one of these little sensors on your skin and leave it on for 10 to 14 days, depending on which sensor you use. This is a Dexcom. This is a Freestyle Libre. and it will give continuous readings every 5 minutes to your cell phone, and you know what happens after you eat cake and ice cream. You know what happens after you exercise. So in real time, you can see what lifestyle does to your blood sugars. Next slide. So diabetes, if one were to give it a definition, it's a metabolic disease in which the body is unable to produce enough insulin, or the person is very resistant to insulin. As a consequence, the blood sugar goes up in the blood. Now, there are different types of diabetes. This is the next slide. In the old days, we classified people as juvenile onset diabetes with a median age of onset of age 13, or adult onset diabetes, which typically was after age 30. The problem with those terms was that there were people 65 years old that were diagnosed with new onset juvenile diabetes. And it's hard to tell a 65-year-old that they have juvenile onset diabetes. The distinction is with juvenile onset diabetes or type 1 diabetes, those individuals have an autoimmune attack on the cells in the pancreas that make insulin. And over time, they lose the ability to make any insulin. And if they don't get insulin, they die. So they're dependent on insulin for survival. But there's some type 1 diabetics, we call them latent autoimmune diabetes in adulthood, or LADA for short. There are some who can go decades without even needing insulin, but eventually they need insulin. But because of this age of onset, not necessarily following the rules in the book, we threw those terms out, juvenile onset and adult onset, because there are some 16-year-olds who are type 2 diabetics. They're adult onset. It's hard to tell a 16-year-old they have adult onset diabetes. So we don't use those terms. We use the term insulin-dependent diabetes for type 1 in the past, but the problem with that was there were a lot of type 2 diabetics who still made plenty of insulin, but they just didn't make enough. So they were on insulin, and they would think they were type 1 diabetics because they were on insulin, and they would think they were insulin dependent, but they weren't. They were just very insulin resistant type 2 diabetics. So we threw that term out. So now we're left with type 1 diabetes, median age of onset 13. They tend to be slender. Type 2 diabetics, median age of onset, over age 30, they tend to be overweight. They can still make insulin. They don't have the antibodies against insulin. They don't have the antibodies against the islet cells in the pancreas that make insulin. So that's the distinction, type 1 or type 2. Now there's another category, there's gestational diabetes, and that simply is diabetes that is first diagnosed during pregnancy. Some of them later will be found to be type 1. If the antibodies are positive and they lose the ability to make insulin, sometimes type 1s will present during pregnancy. The thing about pregnancy is it is nature's stress test to identify those people who are going to go on to be diabetic. If they've got a genetic predisposition to it, the stress of pregnancy, which makes them more insulin resistant, will unmask it. So about half of patients who are diagnosed with diabetes during pregnancy or gestational diabetes will ultimately permanently be diabetic. It's about 50 to 60% by the time you get out to 15 years after pregnancy. There's another category called prediabetes, and these are individuals who have a fasting blood sugar that's above normal, but not above the cut point that we use to diagnose diabetes. And the cut point at which we diagnose diabetes is a fasting blood sugar of 126 or greater. Normal people do not have a glucose when they get up in the morning that's above 100. So when it's in that 100 to 125 range, we call that prediabetes or impaired fasting glucose. Another criteria we can use for that is a glucose after a meal that's above 140. That's not normal. Normal people, after they eat a meal, their blood sugar might go up in the 130s, but it won't go above 140. So if you get a blood sugar of 150 in somebody who doesn't know that they have a problem, they have prediabetes. That's not normal. And if their blood sugar goes over 200 after they eat a meal, that's diabetes. We can use that as a criteria for diabetes. So a fasting blood sugar, when you first get up, 126 or greater, that's diabetes. A random blood sugar after a meal, if it's over 200, that's diabetes. The other criteria we use is the hemoglobin A1C. So your red blood cells contain hemoglobin, and a certain percentage of that has glucose attached to it. And the higher the average glucose in your blood, the higher the percentage of hemoglobin will have glucose attached to it. We call that the hemoglobin A1C. In normal people, it's 4.2 to 5.6. If it's above that, that's prediabetes. If it's above 6.5, that's diabetes. So when we treat a diabetic, we would like to get their fasting blood sugar down to 100. We would like for their blood sugar not to go above about 180 after they eat a meal. Still above what's normal, but acceptable. And we'd like to get their hemoglobin A1C back down to 6.5 because that's the threshold at which we diagnose diabetes. Now, among those who have diabetes, there's probably about 1 in 4 that don't know they have it, that are walking around out there that have diabetes and don't know. We've diagnosed maybe 3/4 of them, but there's a fourth of them walking around that don't know they have it. And a third of us will develop diabetes in our lifetime. And it's a little bit higher depending on ethnic groups, and I'll get into that here in a minute. So next slide. So again, the categories. Type 1 diabetics, they account for only about 5% of all the diabetics. It's usually diagnosed in kids, but it can be diagnosed in 65-year-olds, as I pointed out. And it's when your own body sort of attacks the cells in the pancreas that make insulin, and you end up not making enough insulin. There's not really any prevention for it. Now, in the old days, we used to give people prednisone, cyclosporin, other anti-inflammatory drugs to see if we could delay the onset of type 1 diabetes in those who were high risk and already had the antibodies. And it delayed the onset of high blood sugars by 1 to 2 years. But then you had all the side effects of those drugs for 1 to 2 years to try to prevent diabetes. And so it didn't really work long term. So we've abandoned that. So what are the causes? Well, a lot of it's genetics, and something else happens. We think there's kind of a two-hit thing. You have the genetics for it that you've inherited, and then you get some infection that may unmask it, and then the autoimmune attack starts. So next slide. So what are the symptoms of diabetes? So in this cartoon here on the upper right, you can see, yeah, that's the upper right. If you're always tired, if you're going to the bathroom a lot, if you suddenly lose weight involuntarily, that's because you're spilling glucose in the urine, and those are calories, and that can lead to weight loss over time. If you have infections that just keep popping up, urinary tract infections, skin infections, when your blood glucose is above about 180, it interferes with the action of white cells, and that puts you at risk for infection. The white cells just don't engulf bacteria, and they're not attracted to bacteria normally when the blood sugar is too high. You tend to be hungry because when you don't have enough insulin action, you don't get glucose to go into cells, and so you feel like you're starving all the time because you're not getting the energy into the cells. You may have problems with erectile function as a male because it can damage the nerves that control erections. There may be problems with blurry vision. When you have elevated blood sugars, it draws fluid into the lens of the eye. And if you have drops in glucose fairly dramatically, the vision sometimes gets a lot worse because that fluid slowly leaches back out of the lens of the eye. So the worst time for a diabetic to go get an eye exam is right after they start insulin or started on an insulin pump and their blood sugars come down fairly rapidly, they'll have a lot of blurry vision then, and they'll get glasses which won't work 2 weeks later. So you sort of wait until there's good control for several months before you want to get a new set of glasses. There may be numbness and tingling of the feet. Sometimes that can precede the diagnosis of diabetes. Sometimes people at diagnosis of type 2 diabetes already have complications like the numbness of the nerves and loss of vision and problems with their kidneys. And if you're urinating a lot because your glucose is too high, that's going to make you thirsty all the time. So next slide. So type 2 diabetes, this is the most common type. It's 90+% of those with diabetes. We used to call that adult onset, and we used to call it non-insulin dependent diabetes, but many of them were on insulin, so we don't use that term. And many of them that are diagnosed younger, so we don't use this adult onset anymore. So the body still produces insulin, but people are insulin resistant, so they just can't use the insulin properly. The glucose doesn't move into cells. It goes up in the bloodstream. And the symptoms sometimes are ignored. People think it's just aging, but there's a problem. So next slide. So the risk factors for type 2 diabetes, just like type 1 diabetes, there's genetics involved. Most of the time people think, well, type 1, that's the autoimmune disease, that's clearly genetic, but type 2, that's just being heavy and not eating right. But that's not entirely true. In twin studies, when you look at type 1 diabetics, the ones that are diagnosed at age 13, who don't make insulin anymore, in identical twins, they only have a 50% chance of developing type 1 diabetes if their sibling does. They're identical twin, and they're genetically identical. So there's more to it than just genetics alone. If you look at identical type 2 diabetics, diagnosed older, they're heavier. If one of the identical twins that's a type 2 develops diabetes, his sibling will get it 80 to 90% of the time. So there's a lot of genetics in type 2 diabetes as well. Individuals who have polycystic ovary syndrome with irregular menses are higher risk for type 2 diabetes. They seem to be traveling companions. It is more common for type 2 diabetes in the African American population, Pacific Islanders, Asians, Native Americans, more so than whites. That's in contradistinction to type 1 diabetes. In type 1 diabetes, it's about 1 in 300 Caucasians, and it's the most frequent in Finland, of all places. Type 2 diabetes is less frequent in the African American population. Age, typically after age 30, the median age might be age 45. There are environmental factors. The more active people are and the closer they are to ideal body weight, the less likely they are to become a type 2 diabetic. So next slide. Now we'll talk about gestational diabetes. So this is diabetes that's diagnosed during pregnancy. Individuals that are at risk to develop gestational diabetes are people that already had a glucose abnormality before pregnancy. Maybe they had some impairment of fasting glucose, and then when they get pregnant, then they're just full-blown diabetic. The other thing is if they're heavy going into pregnancy, they're more likely to develop diabetes. If they've got family members that are diabetic, they're more likely to get gestational diabetes. And again, as I pointed out earlier, half of people who are diagnosed with gestational diabetes will be permanently diabetic by the time you get out to 15 years after delivery. If somebody had a baby that was over 9 pounds, that doesn't cause diabetes, but it's a marker saying this person probably had diabetes and we just didn't recognize it during pregnancy. They screen all women in the United States for diabetes during pregnancy, but sometimes people don't get all their, preconception and, gestational checks to have that done. It's about 18% of women that are pregnant are going to be found to have gestational diabetes. Next slide. So what are the long-term complications of uncontrolled diabetes? Well, we sort of categorize them into the microvascular complications, That's those that involve small vessels, for instance, in the eye. So from Perarch's data that I mentioned earlier, the guy that was in Belgium, he found that the people with the worst diabetes control, it was like 70% of them over their lifetime developed bleeding in the back of their eye. And it was like 80% of those individuals ended up with nerve damage. The little tiny blood vessels that feed the nerves in your body will die, then the nerve stops functioning, and then you get the tingling and the burning, and ultimately it can lead to ulcers on the feet and amputations. The other microvascular complication is the little blood vessels in the kidneys can become diseased. And so the first thing we see with diabetics with this complication is they start spilling small amounts of protein in their urine. We call that microalbuminuria. And then ultimately the creatinine in the blood starts to rise, and that's the first signs of kidney failure. Well, that occurs more frequently in people with poor control of their diabetes. There are macrovascular complications, and that's disease in the big vessels. So for instance, the big vessels to the heart leading to heart attacks, and the big vessels going to your brain leading to strokes, and the big vessels going to your legs leading to what we call claudication, where they have to, put stents in and open up arteries that get occluded. If you have good control of diabetes, you're less likely to get those complications. So next slide. So how do we monitor diabetes? Well, finger stick blood sugars, you keep a good diary of what your blood sugars are doing. So again, the classification, normal people, 70 to 100 before meals. They don't go above 140 after meals. Pre-diabetes, they're in that 101 to 125 range before meals. They go above 140, but not above 200 after meals. And then diabetics, they're going to have a blood sugar that's 126 or higher fasting, and after meals, they go above 200. So next slide. So what can we do to prevent type 1 diabetes? Well, it's not really preventable. There are studies to try to halt the progression of the autoimmune destruction. And so there are some studies ongoing where they try to identify certain inflammatory markers in the offspring of type 1 diabetics to identify those who are going to progress to type 1 diabetes in the near-term future. And then we come up with different immune therapies to try to prevent that. And actually, the University of Louisville has an ongoing trial in which we're giving these genetically engineered antibodies to people that we know are progressing to type 1 diabetes to halt that. And we've recruited several patients in that study so far. So if you want to prevent the complications, you need good control of the blood sugars. You do that through insulin. In type 2 diabetics, we have a whole armamentarium of agents that just weren't available before. For like 50 years, we just had glyburide, glipizide type drugs, which potentially can make your blood sugar go too low. And we had insulin, which potentially can make your insulin go too low. Now we've got 6 other classes of drugs that lower the blood sugar, but won't make it go below normal. And so those classes of drugs are less likely to lead to weight gain. And since most type 2 diabetics are going to respond to diet and weight loss, ideally you'd like to reach for a drug first that promotes weight loss. Hence the big interest nowadays in drugs such as semaglutide, the brand name is Ozempic. The equivalent drug that we use for weight loss in non-diabetics is Wegovy. It interferes with the ability of the stomach to empty, so people feel full. They just don't eat as much, and it does lead to weight loss. So next slide. So what can we do to prevent type 2 diabetes from developing or progressing? Well, the first thing you want to do is maintain a healthy lifestyle. So most of my coworkers know that I run marathons, so I run every day. It's just part of my life. It's not for everybody, but anything you do is going to help. Walking is fine. If you have problems with hips or knees or your back, recumbent bicycle or going to a gym and using a pool, aquatic exercise is easier on the joints. People that don't have legs can find a way to exercise. There's always a way to exercise. You just have to be creative and find what your body will let you do. But anything that gets you breathing hard is exercise. If you're not breathing hard, I don't call it exercise. So if you're carrying on a normal conversation, that's not exercise. So you check your hemoglobin A1C, and if it's above target, then you sort of redouble your efforts to bring that level down. If your fasting blood sugar is, not down to 100, then you just keep pushing up the medicine and the exercise and the diet to get those numbers down. And again, my target is to get the hemoglobin A1C in the 6s. If normal is up to 5.6, I'd like it in the 6s. If you get it completely normal, then the trade-off is you're going to start having too much hypoglycemia. And that can be a risk in and of itself. Make sure if you're diabetic that you're getting regular foot exams. And sometimes when people lose sensation, they don't even realize that they've got a complication. Let me just tell you a personal anecdote. When I was in high school, my best friend was Gary Petch. He and I played basketball together. And I went off to Europe between my freshman and sophomore year of college. And I was gone for a couple of years. And when I came home, I sat in, I think, the third row in the back of the chapel at a little church I went to about this size in Hopkinsville, Kentucky. And I sat down next to Gary Petch. He hadn't seen me in 2 years, and we hadn't really kept in touch. So I sat down, and I looked around the little chapel, and I saw this really cute girl. And I said, Gary, who is that creature? And then he turned to me, and he said, Steve, I'm blind. And that was the first I knew that he had lost his vision to diabetes. And he was in his mid-20s. He was diagnosed when he was 9. And, when I was in high school, he used to let me draw up his insulin and give it to him. After he lost his vision, I'd go over to his house, and we'd listen to music. And it'd get late, and we'd be chatting, and it'd be really dark. And I'd say, Gary, do you mind if I turn the light on? And he'd say, oh, yeah, I keep forgetting you have that disability. You need light. And then he'd say, yeah, you can turn the light on. But he said, I never turned the light on, and, well, yeah, it made sense. But most of the local people in Hopkinsville used to say that someday Steve Cavanah is going to go home to Hopkinsville and take care of Gary Petch. Unfortunately, that never happened. He ended up with all the complications of diabetes. He ended up with a combined kidney pancreas transplant. He had a bypass surgery. He had a stroke. He ended up on dialysis, and he was dead in his 40s. So it is a horrible disease when it's not controlled. And I have to confess, he did not take care of his diabetes. So next slide. So as far as preventing gestational diabetes, researchers found that physically active women going into pregnancy are less likely to become diabetic, and you can maintain activity during pregnancy. My wife also was a basketball player, and she actually got recruited out of Moore High School to play in college. She played basketball up until her 7th month of pregnancy. So she's always been very active, so I try to keep up with her. Little side note on her. There was a group of recruiters that came up from Alabama to see my wife play. And that very game, she was the captain of the team and a starter. The coach benched her when the recruiters were there. You want to know why they benched her? She had gone through the neighborhood and found all the for sale signs when she was drunk, and she put them in her coach's yard. True story. All right. So what is the prevalence of diabetes in the United States? There are 29 million in the United States. So it works out to about 9% of the population. And 1 in 4 don't know they have it. So next slide. As far as the overall numbers, undiagnosed, there's probably another 8 million people. So all told, there's probably 30 to 40 million in the United States that have diabetes. And the prevalence in seniors is significantly higher. For those 65 and older, it's like 25% of the population. It's like 1 in 4. And then as far as new cases, it's a couple of million per year now in 2023. And then pre-diabetes, it's probably in the 90 to 100 million range. So there are a lot of people out there that have pre-diabetes that don't know it. I'd say 9 out of 10 people with pre-diabetes don't know it. Their provider may have noticed a blood sugar of, say, 105 or 110, but they didn't really make a big deal about it. But it is a big deal, because if you have pre-diabetes, your risk of progression to frank diabetes is about 5% per year. So over a decade, half of people with a blood sugar that's just a little above normal will be frankly diabetic, and now is the time to attack that. As a cause of death, diabetes is listed as number 7. You know, you got cancers and strokes and heart attacks and all those things, but diabetes alone is number 7. Now, it's associated with a lot of those heart attacks and strokes and cancers, though. So next slide. So this is age-adjusted rate per 100 of non-institutionalized people. And people that are in nursing homes and, you know, hospitalized, there's a much higher incidence of diabetes there. But if you look at it in freestanding people that are walking around, this is broken down based on ethnicity and gender. And the thing that really jumps out here is if you look at the black dots at the very top, that is looking at black females, and then black males is the green dots. And you can see that it's significantly higher than that for Caucasians and for Asians and Pacific Islanders and Hispanics. So there's a distinct risk in the African American population for diabetes. And that seems to also mimic the incidence of obesity as well. It is a big problem in different ethnic groups. This is looking at incidence of diagnosed diabetes per 1,000 population in people that are adults, age 18 to 79. And you can see that the incidence has continued to rise decade by decade. So this is starting back in the 1980s and going up through the past decade. And it exactly parallels the increase in weight gain in the United States. So next slide. This is age-adjusted incidence of diagnosed diabetes per 1,000 in adults based on education. And believe it or not, the incidence of type 2 diabetes is much higher the lower the educational level. So it seems that the people that lowest income tend to eat the fast food and the food that's very calorie dense, and the people with the higher income, they can afford to get a lot healthier food choices, and their incidence of obesity and diabetes is much less. So this is looking at diabetes and obesity over the past several decades, and you can see starting with 1994 and then progressing up to the past decade, those colors, the darker colors, are, so next slide. Next slide. Maybe I've gone too far ahead of you. Yeah, that's the one we're looking at. Sorry, I wasn't telling you. Next slide. So if you look at the far left, that is what it looked like in the United States, diabetes and obesity back in the 80s and 90s. You can see that the lighter colors represent less. And then as you progress to the last, and this is by state, thank goodness for Mississippi and West Virginia. Otherwise, we'd be number 1. But yes, obesity and diabetes is a big problem in the state of Kentucky. So there's research on primary prevention of type 2 diabetes. In the diabetes prevention trial some years ago, they took people that had pre-diabetes, so they were overweight, they had impaired fasting glucose, and they had them do intensive exercise. So they couldn't say, you go home and exercise. They had to come in and punch a clock, and they watched them exercise. And they lost weight. And they watched to see how much they could decrease the progression to frank diabetes. And what they found in that prevention trial is that they could reduce the progression to frank diabetes by 58%. If they took another group and they didn't make them come in and punch a clock and watch them exercise, they just said, I'm going to put you on metformin. Well, that reduced the progression to frank diabetes by 29%, you know. So it appeared that diet and exercise works, but you have to do it. Because the ones that they told to go home and just exercise and diet, well, they didn't do it. And they didn't lose any weight. So what is the cost of diabetes in the United States? So next slide. It's $245 billion a year. So that's, you know, direct medical costs, loss of productivity, people calling in sick because they got to go see their doctor, and, you know, they've got to go to dialysis, or they got to get their toe amputated or whatever. But it is a huge expenditure in the United States. Let's look, next slide, at the global prevalence of diabetes. Worldwide, it's now over 400 million people worldwide have diabetes. And they're expecting another couple of 100 million over the next decade. So what about parts of the world? Well, on this particular slide, I don't think you can see that. The blue there, that's looking at the Western Pacific. And then that slice of the pie that is kind of an orange color, that's Southeast Asia. It's a big problem in the Indian subcontinent. So Pakistan, India, those countries, they have a lot of type 2 diabetes. And it's seen best in the next slide, so why don't we go to that? So next slide. There we go. So this is looking, there are 138 million in the Western Pacific area, 75 million in Southeast Asia, only 22 million in Africa. So there is a distinct difference between the incidence of diabetes in sub-Saharan Africa among African Americans versus Africans living in Africa, and it all has to do with McDonald's. It's all related to our diet and lifestyle. The incidence in South America hasn't caught up. It's only 25 million down there. It's 39 million in North America and the Caribbean. In Europe, there are 52 million overweight Europeans that are type 2 diabetics now. So next slide. So in the United States, it's probably closer to 90 million pre-diabetics in the United States. And about 5% per year are going to progress on to diabetes. So next slide. So I'd mentioned this diabetes prevention program. So the summary to that is type 2 diabetes can be prevented and delayed with activity and diet. And usually people ask me, well, what kind of diet? Any diet that leads to weight loss is good. Now, in terms of keto diet, people do lose weight. All of the parameters get better. But when you eat, bacon, people lose weight. They look great when they have their heart attack, basically. My preference is a Mediterranean diet. I think that's probably the most healthy way to lose weight in the long term. Any diet that works, I'm fine with it. But you probably don't want to be eating a lot of dairy and saturated fat and eggs to lose weight. So what can you do? Well, eat right, lose weight, be more active, and then you can manage diabetes. Work with your healthcare providers if you're diabetic, diagnosed. Make sure that you keep a log of your blood sugars so you know what activity and food is doing. Again, I'd mentioned these twin studies. It's very genetic in type 2 diabetes as well as type 1. Sometimes people will say, well, I'm fat because my parents are fat and my grandparents are fat. There's actually a lot of truth in that. So if you take a specific kindred, for instance, if you line up 100 Cavanahs that look that are related to me, we all look alike. You can't pay us enough to gain weight. I eat 6,000 calories a day, and I probably weigh the same thing now that I weighed in high school. It's genetics. So, but, yeah, I know. Now, my wife struggles with her weight, but I learned early in marriage not to mention a thing about it. I always tell her, you look great just the way you are, and I'm still married 39 years later. So next slide. Let's go past that slide. So the future. There are a lot of research, there's a lot of research going on now about regenerating human beta cells, basically taking beta cells from individuals and then reconstituting it and putting it back in them, or getting donor beta cells that make insulin to put in there. We've been transplanting beta cells into livers for a long time. The problem is eventually they fail. They work for a few years. Sometimes people are completely insulin-free with these islet cell transplants for up to 5-10 years, but they ultimately, that same autoimmune attack occurs again, and they end up type 1 diabetics again. So we'll go to the next slide. Another thing that's been looked at in animal studies is you can do transplants of brown fat into individuals that are insulin resistant, and that does seem to have a benefit, at least so far in animal studies. So there's different types of fat. There's the white fat, which is subcutaneous fat. That's the bad fat, and it's around all the internal organs. That's an inflammatory state, and it can lead to heart attacks and all those things. But brown fat is contained in muscles, and it's thermogenic. It helps you generate heat, and that's the fat you sort of need in cold weather, as an example. And it serves a vital function. So in skinny people, they have a disproportionately more brown fat than in heavy people who have a lot more white fat. So brown fat is good, white fat is bad. So these are some websites, next slide, that you can go to get information on diabetes. I thought what I would do now is just show you a few things. So this is show and tell. So this is an insulin pump and a continuous glucose monitor device. This is a continuous glucose monitor right here. That's the Dexcom. So it talks to the pump. So in real time, you have a blood sugar from the continuous glucose monitor. It tells the insulin pump to pump more insulin or to stop pumping insulin. So it's become quite sophisticated. It's essentially like a pancreas that you wear. There is talk of implantable insulin pumps that you can fill through the skin. That's the future right now. But these hybrid closed-loop systems have been perfected. There is the Omnipod, which is an insulin pump that does not have tubes from it. It communicates directly with a Dexcom sensor like this. And if the blood sugar goes too high, the Omnipod cranks out more insulin to get the blood sugar down, and it aims for a tight range. And with these hybrid closed-loop systems, we can get someone's blood sugar in the target range 80+% of the time. And that seems to be the big key in preventing long-term complications, not so much what is their hemoglobin A1C, which tells us their average blood sugar, but what percentage of the time are they actually in the target range, 70 to 180. And if we can keep them there 80% of the time, they're not going to get the long-term complications. And so that is the future of diabetes right now. So I've got some little handouts here to give you. And I thought what I'd do is just kind of open it up to questions at this point. So any questions that you have? Yes, I'm going to give you the microphone.
Yeah, my question is, you mentioned the connection between kidney disease and diabetes. I was wondering about the opposite, is if kidney disease will impact whether or not you develop diabetes.
It's usually the reverse. In fact, diabetics who develop end-stage kidney disease, because the kidneys have insulinase activity which clears insulin, sometimes poorly controlled diabetics, when they have end-stage kidney disease, suddenly they don't need any insulin because their insulin that they're making hangs around so long, and it's supposed to be cleared by the kidneys. So usually it's, if you go to any dialysis center, about half the patients there are diabetics that are on dialysis because of end-stage kidney disease from diabetes. So it's usually not the reverse. Next question.
On your sensors, how do you connect those to the body? Does it have to be like a stick?
Yeah. So it has a little filament that it has an introducer, so you put it on your arm and you push it and it fires it through the skin. So, and then you pull the introducer off and the sensor stays there. So it's got a filament that goes under the skin. It's not actually measuring blood glucose, it's measuring the glucose in interstitial fluid, which is kind of not exactly the same, and there's a little bit of a lag time. So if you do a finger stick glucose after a meal, that's probably going to give you real-time information. If you looked at a glucose sensor at the very same time, it might lag behind by about 15 or 20 minutes. So in the fasting state, before you eat meals, the sensors are right on. Right after a meal, they may lag a little bit. And you leave them in there for about 2 weeks, and then you pull it out. So it looks like this flat disc on your skin, but you pull it out, and then this long little thread comes out through the skin. You leave them in there 10 to 14 days. Sometimes people have trouble keeping them on, so they'll put like a bandage over the top of it to kind of keep it there. But every time new technology comes out, I wear it myself for a couple of weeks just to see what it's like. So when patients tell me they had this problem or that problem, I can say, yeah, I did it myself, and I know what you're talking about. There's nothing worse than have a doctor talk to you about something that they've never experienced. So I wear these things all the time myself. I'm not diabetic, but I've worn an insulin pump multiple times just to get used to them. And I've worn the continuous glucose monitors. My blood sugar is always normal, but I've done it just to have the experience. Yes?
What is categorized as pre-diabetic in terms of your glucose numbers and hemoglobin?
So again, you're pre-diabetic if your fasting blood sugar is above 100, but not above 126, or if your blood sugar after a meal is above 140, but not above 200, or if your hemoglobin A1C is above normal, but not above 6.5. So it's that gray area between normal and diabetes. And again, 5% of those people per year will progress on to diabetes. And in general, we picked that cut point of 126, and I remember when we picked that number, it was because a fasting blood sugar of 126 is the threshold at which we start getting complications of diabetes. If people have a blood sugar under 126, they tend not to get those complications. So that's the cut point where we said, okay, that's where diabetes is, because that's where we start getting the complications.
Dr. Cavanah, we have a question from our social media site.
Okay.
And it says, what are some common myths about diabetes?
Okay. Does eating ice cream every day cause diabetes? No, but if you're diabetic, your blood sugar is going to be a lot higher. So I eat ice cream every day. And I'm not going to get diabetes because none of my relatives have it. Your diet, in type 1 diabetics, the diet will cause your blood sugar to go higher if you have the problem, but in and of itself, it probably doesn't cause diabetes unless it causes you to gain weight over time. But if you eat the wrong diet all the time, it'll make you, it's kind of an inflammatory state, a lot of high carb food. So if a dietitian were to talk to you, they'd say, by all means, don't eat that stuff if you don't want to be diabetic. But truth be told, it doesn't cause type 1 diabetes. It's just if you're a type 1 diabetic, you don't want to eat that stuff because it's going to make it harder to manage your blood sugars.
Yes, doctor. Say if you have type 1 diabetes and you get that pump and everything works out, is the damage that's already done from your diabetes, will that be cured?
So once somebody gets the microvascular complications, can there be reversal? Well, there have been studies showing that the amount of protein in the urine can be decreased once people achieve really good control. It probably won't go to normal, but you can stop the progression and maybe get some improvement. It's the same with nerve conduction studies and people that have advanced diabetic neuropathy. If they had developed really good control for a period of time, repeat nerve conduction studies have shown some improvement. The same is true of vascular disease in people that have coronary atherosclerosis. When people go on those injections twice a month, Praluent and some of those type drugs, or intensive statin therapy, repeat coronary angiograms later show some reversal of the blockages in those arteries. So you may not get everything to go back to normal, but some of those complications can be arrested at the point at which they're at, and hopefully there won't be progression.
What type of impact does a plant-based diet have? I've heard a lot about, that you can reverse conditions and a lot of different things. Can you elaborate on that a little bit?
So if someone goes on a plant-based diet, there's a dramatic improvement in lipids, as an example. So if somebody, let's say they have familial hypercholesterolemia and their cholesterol is 350 and their LDL cholesterol is 250, with normal being under 200 for a total cholesterol and under 100 for an LDL cholesterol. If somebody goes on a completely plant-based diet, strict vegetarian, so no more meat, eggs, dairy products, they can lower their LDL cholesterol by about a third. So that's significant. So if you're talking in their total cholesterol, if it's 350, you drop it a third, well now it's 225. I mean, that's dramatic improvement. And you do see reversal of pre-diabetes. So we see this all the time in people that lose 50, 100 pounds. They can have profound hypercholesterolemia, diabetes, hypertension, gout, gallstone disease, all these degenerative joint disease, obstructive sleep apnea. All these things are complications of diet and obesity. If people lose 50, 100 pounds, it all goes away. And people that have gastric bypass surgery, poorly controlled diabetics, type 2s, they lose 80, 100 pounds, they end up on nothing for blood pressure, diabetes, it all goes away. Sometimes they're on, very minimal medicine, whereas they had 20 different meds before they lost all the weight. So a lot of the medications that we prescribe in the United States today, we could get rid of them all if everybody was ideal body weight. But we're not. We're victims of our own largesse in this country. Too much success leads to bad health. So, my voice is like this all the time. Thanks. Another question. Well, low birth weight's bad, and then 10-pound babies, that's not good. Studies of gestational diabetes have shown that that's not healthy for the baby in the long term. There's a higher incidence not only of obstetric complications of trying to get that basketball out through the womb, but long term there are problems with diabetes and the offspring of mothers with gestational diabetes. It sets the tone for that kid for later in life, so that's a problem. Now, in terms of risk to kids, let's say it's a type 1 diabetic mother and she has a child. This question comes up a lot. What is the chance that my child is going to be a type 1 diabetic? It's about 5 or 6%, depending on whether it's the father that's a type 1 diabetic or the mother is a type 1 diabetic. But yeah, on average about 5%. So 1 in 20 offspring of a type 1 diabetic will be a type 1 diabetic. If it's type 2 diabetes, on the other hand, if you have two parents that are both type 2 diabetics, then there's probably, 30%, 40% chance that that child in their lifetime will be a type 2 diabetic. Some of it's, nature, some of it's nurture. People inherit not only the genetics, but they inherit the lifestyle and the eating patterns of their parents as well.
In the schools, and we have had an amazing amount of elementary school kids that are well over 150 pounds, and we're having trouble with like mobility and all of that. And I don't know that a lot of the kids are on medications, so, or if they, it's really sad.
Yeah, we need to bring PE back in the schools. Yeah. Yeah. It's a. Yeah, kids need to learn, to exercise and get into some sort of exercise that they can stay with the rest of their life. People that play football in high school, they're not going to play it the rest of their life. There's not that many end up, doing that as a career. So there needs to be a plan B to stay healthy. To put that in context, in 1960, it was 1 in 500 people was 100 pounds overweight. Now it's 1 in 20. 1 in 500 in 1960, 1 in 20 now, more than 100 pounds overweight. So it's a huge problem. And if you look at people over 40, it's like 40% of people are obese. It is a big problem in the United States, and that translates into type 2 diabetes and hypertension and high cholesterol, and then heart attacks and strokes down the road. Any more questions? I could go all night, but you guys probably want to go home. Let's see, 8 o'clock. So I'll stay as long as you want, if that's good. Help yourself to these little pamphlets, and you can keep them for Sunday worship if people want some of those too. I was happy to be here. Thank you.
Thank you, Dr. Cavanah, and we really appreciate the learning today. We got some great information. I'm sure our live streaming was able to get some information too as well. And one of the things, I just came under so much conviction just listening to him. While he was talking, I was going through my chart, looking at my numbers, and I was looking to see where I was on different things. And I'm approaching that pre-diabetic. That's on the numbers. That's what I was asking. So I know I can do some things today to prevent it. So you may have saved someone's life. I want to see my grandkids. So we are definitely going to work on it, my wife and I. And I think it's something in terms of, we have talked about this before, but having a health ministry at the church in terms of being able to really deal with things like this. This is just so invaluable in the community. And if you notice, on every chart, African Americans are at the highest of all of that, whether it's genetic, environment, used to eating different things, but we have an opportunity to change that. And it begins with us. And it's so easy to talk about, I want to do it, but to go actually exercise and eat, that's where we need support and help. So maybe we can come up with something, think of something. I'm open to something as a congregation that we can look at doing that can help to support people who are trying to live healthy and want to encourage one another. Even if we have to bring in some therapists, maybe need therapists and doctors and nutritionists, they're available. We just need to access it and then do it. With that being said, thank you, Brother Mark, for putting all this together and getting Dr. Cavanah here today. And we're encouraged to share with all that we can do better than where we are, and we can actually see improvement. And so, again, we are encouraged by all that we see and do. If our hearts and minds are clear, let us get ready to pray to receive the blessings of the benediction. Father in heaven, we thank you so much for the privilege you've given us to hear the word tonight about our health. I pray, God, that those who heard online and even here, that it convicts us to change habits, that we can prevent some things from happening, and we can slow down some things from happening. I pray that you would give us the conviction and the mindset and the will to be able to make the necessary changes that we need to have better health outcomes in our lives. We honor you with all that we have and all that we do. We ask all these blessings in the name of our Lord and Savior, Jesus Christ. Amen. Be blessed.